Okay. The topic for this presentation is initiating CBT for coexisting opioid use disorder and chronic pain. So approximately 40% of patients questioned with opioid use disorder had chronic pain prior to their opioid use disorder diagnosis. If that chronic pain is left untreated, it persists, often leading to opioid use relapse following opioid detoxification. So chronic pain often leaves patients unable to complete activities of daily living, activities they previously enjoyed, and lead to an overall lower quality of life. Ineffective management of chronic pain often leads to misuse of opioids. Patients, in essence, will self-medicate in an effort to get their pain under control. Opioid use disorder causes intense cravings that leads patients to prioritize opioid use over other responsibilities like family, personal finances, work, school, etc., and leaves patients unable to function in a normal society. So what is cognitive behavioral therapy? It's an evidence-based intervention that modifies beliefs and maladaptive behaviors. The patient first learns to recognize their behaviors as maladaptive. The patient then learns and implements new adaptive behaviors to replace the old ones. So as far as benefits for opioid use disorder go, patients learn to recognize situations that they are likely to result in relapse of opioid use, and learn new coping mechanisms to deal with those situations without using opioids. It also encourages engagement with adherence to the treatment plan, including pharmacotherapy. It also treats underlying psychiatric disorders that either complicate or act as a trigger for substance use relapse. So the benefits for chronic pain. Cognitive behavioral therapy will focus on improving pain coping mechanisms, so like active pacing, distraction, pleasant activity scheduling, etc. It also focuses on altering behavioral responses to pain and using those new coping mechanisms to ultimately abstain from using opioids. So as far as the population of interest and the goal of the project goes, this project will focus on patients with opioid use disorder that also have coexisting chronic non-cancer pain. The goal of the project is to determine if implementing cognitive behavioral therapy, an evidence-based intervention for both chronic pain and opioid use disorder, in conjunction with medication-assisted therapy that's already being provided for both the chronic pain and the opioid use disorder, will have an impact on the success of the patient to maintain sobriety following discharge from inpatient detoxification. For the clinical guidelines in regard to treating opioid use disorder, psychosocial therapy combined with pharmacological therapy improves outcomes significantly and should be used as a part of a comprehensive treatment plan for those with opioid use disorder. They've known for a long time that that pharmacotherapy on its own just doesn't cut it, and that it needs to that somehow the behaviors that got them into the into the situation that they're in, somehow those behaviors need to be changed. So the clinical guidelines for treating chronic pain, psychosocial therapy, along with other non-pharmacological interventions, should be used in conjunction with non-opioid analgesics to treat those patients who have chronic pain. And this is a little bit of a change from how chronic pain has been dealt with in the past. It seems like since the mid 90s, I believe I read in a few different articles that that the prescribers would just throw opioids at it and hope hope that it would work. When in essence, what they've done is they've raised the tolerance for those patients by giving them opioids for so long, and patients end up self-medicating and raising the doses on their own, and seeking multiple providers and things along those lines that eventually wind up putting them in a position where they're addicted to something like heroin or fentanyl that can be easily found on the black market. So part of the assessment, each of the assessments that'll be taking place will be the clinical opiate withdrawal scale. This uses a point system that allows the provider to accurately time the first dose of Suboxone or whichever med they choose to use. Typically, it's either Suboxone or Subutex. But at any rate, it allows them to time that first dose so that the patient doesn't enter what's referred to as a precipitated withdrawal. So withdrawal symptoms such as GI distress, yawning, sweating, runny nose, tremors, goosebumps, etc., they're all assigned points. And when the score reaches a level that's predetermined by the provider, the medication-assisted therapy can then begin, again, so that they don't start into a precipitated withdrawal. A precipitated withdrawal is an immediate onset as opposed to a slow and steady onset of severe withdrawal symptoms that occur when medicated-assisted therapy is started too early and while there's still a significant level of opioids in the patient's system. A pain assessment will also go along with each appointment through the process, and we're just going to use a visual analog scale. The patient's shown a 100 millimeter line at the left end of the scale equals no pain. The right end of the scale equals the worst imaginable pain. The patient is asked to point to the area on the scale that best indicates their level of pain. Provider then uses that data to determine a baseline level of pain for the first appointment, or to determine whether the chosen intervention is working. So for appointments 2 through 12 down the line, they can see if if the interventions that they're choosing are working. So for patients with chronic pain, this assessment is performed with every encounter. The current literature states that long-term use of opioids likely puts a patient with chronic pain at risk of developing opioid use disorder. Efforts to reduce overdose on opioids are becoming a serious public health concern due to the recent increase in overdose deaths and ease of access to drugs like fentanyl on the black market. The CDC has established new guidelines for management of chronic pain that leave out the use of opioids in an effort to prevent addiction. Cognitive behavioral therapy combined with pharmacological interventions is shown to be much more effective than pharmacological interventions alone. In this study, it was shown that addiction severity index scores decreased for the experimental group, which the experimental group in this study had both CBT and MAT. The perceived stress scale scores also decreased for the experimental group. And also the number of positive opioid urine screens decreased for the experimental group, indicating fewer relapses. And that's really important for what we're looking at. That's our ultimate goal, is to is to keep them from using opioids. And seeing the decreased number in urine screens, that's a data point you can quantify. And one that we will look to to reduce when we implement the project at UTMC. There are some inconsistencies in the literature. for instance, many inconsistent definitions in like dependence, substance use disorder, misuse, addiction, abuse, they all seem to be used interchangeably, even though they're not really necessarily the same thing. There's also conflicting research on coexisting chronic pain and opioid misuse regarding prevalence, risk factors, and clinical management approaches specific to this growing population. There's research out there that maybe it's not as prevalent as we think, even though if you've practiced in this area for any amount of time at all, you know that's just not the case. It is a growing problem. Most of the literature will tell you that, but there is still some conflicting research out there. The PICO question for this project is: in patients who have chronic non-cancer pain and misuse opioids, does cognitive behavioral therapy, compared to no cognitive behavioral therapy, in conjunction with pharmacological treatment, result in fewer opioid misuse relapses after 1 month, 3 months, and 6 months? So the theory I chose to guide this project is Orum's self-care deficit theory of nursing. This framework was picked to guide this project because of its emphasis on identifying self-care deficits, teaching the patient how to deal with those deficits, and having the patient deal with those deficits on their own once they learn. This theory works well with the chosen intervention because cognitive behavioral therapy aims to achieve basically the same goals. Again, we're looking at modifying behavior. We teach the patient how to modify their behavior. Well, first get them to recognize that the behavior is bad, teach them how to deal with it, have them deal with it on their own. So many patients that have both chronic non-cancer pain and opioid use disorder have many self-care deficits. These self-care deficits include like inability to perform ADLs, food insecurity, housing insecurity, inability to secure reliable transportation, inability to maintain employment, low health literacy, things that a lot of us take for granted, quite frankly. The simple day-to-day stuff that many of us do without even thinking about it, these folks just are unable to complete. So cognitive behavioral therapy targets specific symptoms and problems to change behavior related to that problem. Orum's self-care deficit theory takes that same approach, targeting specific deficits in order to change behavior related to those deficits. So as far as the feasibility of the project goes, I found an inpatient facility willing to move forward with the plan. UTMC Recovery Services, both inpatient and outpatient units, are gonna go along with me. The required team members are already in place and are fully qualified to initiate the intervention. And I've got a meeting scheduled to discuss possible costs associated with the project and possible funding options. So I'm actually quite happy with how this is moving along. So to evaluate the project, outcomes from implementation of cognitive behavioral therapy, they're going to include higher rates of opioid use abstinence from baseline as evidenced by fewer UTOX screen results, clinically significant reduction in pain from baseline, and a higher rate of participant satisfaction with the treatment plan. Each of these points will be measured at each outpatient appointment and recorded. These are all incredibly, important things to see to encourage adherence to the plan. If any of the three of those are not met, the likelihood for success is very low. So those are three very important points that we need to see improvement on. So So chronic behavioral therapy and medication-assisted therapy for chronic pain and opioid use disorders have the potential to reduce the number of opioid use relapses and decrease the level of pain for this population. Essentially, what we're looking for is to provide, is to provide this population with the ability to participate in society and provide them with a greater quality of life. As far as limitations go, the most glaring one to me is that this patient population may have trouble maintaining adherence to such a long program. It's 12 weeks long, due to issues like lack of reliable transportation and environmental factors that could possibly lead to relapse. These environmental factors include returning to the same environment following inpatient detox. They may not have any other place to go other than the house that they just left. And to you and I, that sounds okay. But for instance, if they didn't do something like, many of these folks have stashes of illicit opioids all over their house. If they either forgot to get rid of them prior to detox or whatever, they're returning to an environment where opioids are readily available and are very easily and could very easily relapse in that situation. Also, being around the same social groups as before they went to detox, family and friends who also use or misuse opioids. That's a huge trigger for a lot of this population. They end up going back to the same environment that they started in, and it's very, very easy for them to slip right back into the old routine. So as far as future plans go, I've spoken with and presented evidence to the attending psychiatrist that oversees the Inpatient Recovery Services Unit at UTMC, and he's agreed to meet and discuss further plans to have session 1 in the inpatient unit prior to discharge, and sessions 2 through 12 of the cognitive behavioral therapy at UTMC's outpatient recovery services. So again, in the inpatient setting, we will begin medication-assisted therapy, get the withdrawal symptoms under control, initiate session 1 of CBT, and then discharge from the inpatient unit. In the outpatient setting, we will maintain medication-assisted therapy, make medication changes as needed, and continue with sessions 2 through 12 of CBT. And there are the references.